Good morning, good day, and good evening to our international audience, and welcome to another exciting webinar, as always broadcasted here in Overath, close to Cologne in Germany. My name is Matthias Geuter. I'm head of marketing here at Spiegel & Theis Medizintechnik, and it is my pleasure of hosting today's webinar talking about balloon eustachian tuboplasty, abbreviated and known as BET. The 680 registrations that we have received worldwide for this webinar are a clear indicator that there's a very high interest in this modern, innovative, and non-traumatic way of treating eustachian tube dysfunctions. A result that makes us very proud. On top, I would also like to welcome a group of 35 Italian physicians that just completed a 2-day BET workshop and just dialed in to not miss out the opportunity to listen to our two speakers today. In other ways, welcome and also buongiorno down to Rome. To give you a 360 view of the world of BET and to help you to better understand the way eustachian tube dysfunctions is treated and diagnosed, we are very happy to welcome the two godfathers and pioneers of BET. They will share their world-class hands-on experience and answer all your questions towards the end of the webinar. To start off with, we will listen to Dr. Dennis Poe, who is professor at the Harvard Medical School in Cambridge, Massachusetts, and who's also practicing at the Children's Hospital in Boston. He will primarily talk about testing, diagnose, and the candidacy for balloon dilatation. We will then listen to Dr. Holger Sudhoff, who is professor at the University of Bielefeld and actually has to be considered as the godfather of BET, since he invented and developed, together with Spiegel & Theis, the first dilatation system that was exclusively designed to treat eustachian tube dysfunctions only. Since the launch of the product, he already placed more than 6,000 catheters and thus became the most experienced physician within this field. He will primarily talk about best practice, safety and efficiency, and long-term results. But now, let's hand over to Dr. Dennis Poe, who's already waiting for us in Boston. Before I hand over the microphone to him, just want to please make sure you send all your questions using the Teams chat option. We are very excited to listen to him and to answer your questions again in the end of this webinar. So thank you very much and enjoy Dr. Poe's speech. Thank you very much.
Good afternoon, everyone. Ladies and gentlemen, thank you very much for the privilege of this opportunity to speak with you today. And we greatly appreciate your taking the time to join us for this presentation. I would like to thank Spiegel & Theis for hosting this informational webinar, and also a special thanks and greetings to my good friend and colleague, Professor Holger Sudhoff, who has been an important pioneer in this field, and he brings to you the world's greatest experience. I'm Dennis Poe at Boston Children's Hospital and Harvard Medical School in the United States, and I'll be speaking to you first about the office diagnosis and management of eustachian tube disorders. So, the revelation that has made surgery in this field possible has been the finding that the principal cause of obstructive eustachian tube dysfunction occurs within the cartilaginous portion, an area that we now call the valve, where the walls meet, and not as commonly in the bony isthmus as was thought in the past. Here are endoscopic views of a right eustachian tube. The torus tubari is here, and this is the valve with the lumen closed in the resting position. We'll talk about the two walls, the membranous wall, the cartilaginous wall, and how those have to dilate open by the action of the muscles when we swallow or yawn or other maneuvers. The principal function of the eustachian tube is to aerate the middle ear, and here we see a study from POE et al. In Rostock, where the volunteer subjects refrained from swallowing or yawning for as long as they could, and they got up to 2 hours before it became too painful. The idea was to prevent the eustachian tube from opening, and these are tympanograms showing how the pressures became negative to minus 100 in just 1 hour and minus 170 by 2 hours, at which time they all quit. So this is an example in humans of the active middle ear gas exchange that's absorbing the gases at all times. And our eustachian tubes have to open several times an hour to prevent accumulation of this negative pressure. So the consequences of obstructive eustachian tube dysfunction are that the pressure can continue to worsen negatively with consequences. So we want to be aware of the surgical anatomy of the eustachian tube. This is a cadaver longitudinal section, and it shows here from the nasopharyngeal orifice. This is the cartilaginous portion that goes to about 25 millimeters to the isthmus, and then opens up from there to the middle ear, the bony portion. So this is the functional part of the valve, and it's most commonly obstructed with inflammatory disease. Note that here is a cross-section histologically of the cartilaginous wall, the membranous wall, and note also the curvature. The eustachian tube is actually quite curved, and when we want to introduce our endoscopes or catheters into the eustachian tube, you want to follow the membranous wall, not the torus. If you follow the torus, it will bring you in contact with that membranous wall, and it's very, very thin, very easy to puncture. You can get a false passage. We'll follow the membranous wall, and Professor Sudhoff will talk about that later. Pediatric considerations are dominated by variations in the anatomy and inflammation. Here's a recent CT measurement study of the cartilaginous portion of the eustachian tube, and we found that it ranges from an average length of about 20 millimeters in the young under 2 age, up to about 27 millimeters mean in the 15-year-old and above. Notice that the greatest slope of growth is here between the 6 and 14-year period, after which it starts tapering off to the adult. We've been previously told that the eustachian tube is full adult size and dimensions by age 7, but that's histological data, and we're seeing some differences here. So this is important when you're treating children. You want to be aware that a shorter length of introduction of any catheters into the eustachian tube is appropriate. So the other important consideration is that this height of the orifice of the eustachian tube from the nasopharyngeal floor, from the nasal floor, is going to be lower. So you'll have a reduced angle in the pediatric patient compared to adults, where that angle is going to be higher and more acute. Another big difference is that there's a greater burden of inflammation in the children. So here we see left eustachian tubes, the lumen and the torus is very boggy, very inflamed, and very large adenoid hypertrophy, whereas in adults, you can still see robust inflammation, but it's usually not to the same degree. And the children seem to respond. Their inflammation is more robust, but they respond more readily to treatments, and that's important both medically and surgically. So in children who are old enough to do an endoscopy in the office and adults, we like to look at the eustachian tube with a dynamic view while they're swallowing, yawning, and vocalizing ah. These maneuvers, swallows will give you a physiological opening, and the yawn or ah will give you a maximal dilatory effort. I have them start out saying ka, 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 so that we see some movement of just the levator muscle, and then the other will combine the function of the tensor veli palatini muscle to open the valve. We like to look generally with an angled view. A 0-degree endoscope often will not give you an adequate view of both walls. You'll see the torus and the adenoid, but not always the membranous wall. Here's a 45-degree scope, which is optimal. 30-degree works well also, and we see both walls very well. These are right sides, torus, and cartilaginous wall, membranous wall. Here's how I typically do that. I use a fiber optic endoscope. It's in the nasal cavity, in this case going through the left nostril. I'll withdraw the endoscope into the nasopharynx, turn it 90 degrees, and I can go back and forth across the vomer now. I'm looking now at the right eustachian tube, and I've just turned the camera to write the image. Patient will vocalize ka, ka, ka to activate the levator, and we see how well that rotates the torus medially. And then the swallow to look at the physiological opening, and the yawn or vocalizing ah for a maximal dilatory effort, and this happens to be a patulous eustachian tube. And then we'll repeat that on the other side. Here is the adenoid. And this is a common scenario where we see some mucus in the way. Now we really want to be able to see both walls. So we won't let that stop us. I'll just go right through that mucus, and now we have a great view of the two walls, and with the same maneuvers. So that's the office exam. That dynamic exam is important. Here are some cases. A right side allergic hypertrophy, and here we see the hypertrophy of the torus tubaris. Adenoid's only barely touching the torus. Doesn't look to be a big factor, but watch what happens when she swallows. This is anterior thrusting of the torus being trapped between the adenoid hypertrophy, which is only moderate, the hypertrophy of the torus tubaris and the inflammation in the lumen, traps the torus, thrusting it anteriorly, closing the valve, and this patient has a chronic effusion from allergic disease. So you wouldn't recognize this if you only looked at this static view. It's important to look dynamically what happens during these swallows and yawns to really see the pathology. Now contrast that to this allergic rhinitis patient. Again, a right side, very robust inflammation here at the orifice. But look just inside the valve, that yellow in the membranous wall is the Ostman's fat being seen through atrophy of the mucosa and submucosa. And this is very common with chronic allergic disease, where there can be patches of atrophy, burned out mucosa from being overstimulated in the nose, sinuses, and apparently in the eustachian tubes. And that can lead to a patulous eustachian tube, even though the patient may have robust inflammation in the nasopharynx and even at the torus. Now let's look at the examples of adenoid hypertrophy, how they can affect the torus and the lumen. So these are right eustachian tubes, very robust adenoid hypertrophy, large hypertrophy and cobblestoning, lymphoid hyperplasia of the torus tubaris. Watch what happens when this patient swallows. Severe anterior thrusting, closing the lumen. So this patient has a chronic effusion, and it's not surprising. Now contrast that to this patient who has an equally large, if not larger, adenoid hypertrophy, quite a bit of hypertrophy of the torus, cobblestoning of the tubal tonsil tissue, but the lumen is open. There's a scaphoid hollow here in the adenoid just by its geometry that's accommodating the torus. So when this patient swallows, there is no anterior thrusting. So we see a robust inflammation in the nasopharynx, but a normal eustachian tube function, normal ear. So again, this dynamic examination is very important to try to sort out the pathology and the mechanisms. Now we think of eustachian tube dysfunction now as a spectrum, ranging from complete obstructive dysfunction with an effusion all the way up to patulous. And it's a spectrum because the same conditions can cause different types of pathology on the spectrum, and the patients can actually go back and forth. So here we see an example of Samter's triad with severe inflammation, thick mucus. This eustachian tube never opens, and they have a middle ear effusion. If you have a lesser degree of inflammation, this tube can open sometimes, and we have retraction, negative pressure, but without a middle ear effusion. Here we have a minimal amount of inflammation. It's actually just confined to this band of inflamed mucosa here along the floor. And this patient only has trouble with baro challenge, flights or diving. They come in the office with a normal ear under normal circumstances, and minimal inflammation may require just minimal treatment. So this is important in our decisions for surgical management. Now, if you have that situation, particularly with common with chronic allergic disease, causing patches of atrophy and burned out mucosa, as you see here, you can get a patchless eustachian tube. And the patient can have excursions of the tympanic membrane with ipsilateral nasal breathing, the opposite nostril closed and the mouth closed. This kind of atrophy can become obstructed again if their allergic disease comes out of control. They can even become back on this end of the spectrum with a middle ear effusion. But if their disease is quiescent or they're over-medicated, they can become patchless again. And they can fool us by telling us chronically that they just have a blocked ear. So you really have to be asking about symptoms of patchless eustachian tube. Now be aware that the retraction pockets that become fixed to the middle ear mucosa can progress due to upregulated inflammatory mediators. And this was seen by Jan Grote and Rick Cole. These inflammatory mediators can cause epithelia spreading and fibrosis, deepening of a retraction pocket, even to the point of causing cholesteatoma, independent of the eustachian tube function at that time. So as an example, this pocket has been progressive, and yet this patient has a normal eustachian tube and a type A tympanogram. This patient, if symptomatic, needs a cartilage tympanoplasty, not a balloon dilation. So to summarize this, assessing for obstructive eustachian tube dysfunction, who might be a candidate for a balloon dilation? These patients typically are baro challenged. They may have had otitis media, especially in the children. They generally cannot do a modified Valsalva maneuver. Now, I don't like to teach a true Valsalva where you hold the nose, mouth closed, and blow hard. I've actually seen people destroy their sensory neural hearing and become vertiginous. So we teach a modified Valsalva, nose and mouth closed, only gently blowing, raising the intranasal pressure, and swallowing at the same time to use the dilator muscles to open the eustachian tube rather than forced pressure. It's safer and much more effective. All the scuba divers learn to do it. I even try to teach the children to do this. Remember to ask about autophony of voice and breathing. And now you know how to look for negative pressure, otoscopy with insufflation, and you know how to recognize retractions or effusion. Again, it could be normal if they're only baro challenged when they're in the office. Audiogram will show a conductive hearing loss if it's active, tympanogram type B or C, and this all-important endoscopy with the dynamic swallows and yawns and ahs. And I have a memnonic here looking for signs of inflammation, mucus, edema, erythema, lymphoid hyperplasia. That's adenoid-like tissue that's gotten into the lumen of the eustachian tube, causing that the obstructive pathology. And how well does that valve open? This kind of knee-low assessment of the bullet points that I look for. Keep in mind, if the patient has had a myringotomy or tube grommet, it should relieve the symptoms of obstructive eustachian tube dysfunction. If it does not relieve it, there's another diagnosis likely going on. So here's a view of a normal. This is a 0 degree left side, and we don't see the membranous wall. So we'll switch to a 45-degree rigid scope in this case, and there's a swallow. So this is a normal, and we're going to look at how the valve opens normally in slow motion. So there's a swallow, and what we'll see is the levator elevating the palate first and medially rotating the torus tubarius, against which it's going to stay medialized, against which the tensor veli palatini muscle will fire. So here's the levator medializing the torus. Watch the tensor fire now to open the valve. And all of this happens in under a second. The valve is open, typically about 400 milliseconds. And here you see in this cadaver dissection, those muscles where they lie, the levator in the floor, the tensor in the membranous wall. So this is what we want to see, is this 1-2 action, the levator, the tensor, and this opening. And we'll assess for inflammatory disease and how well does that valve open. So this is an algorithm that we use in the office every day. The diagnosis, differential diagnosis of aural fullness. The patient with the retracted tympanic membrane, it's usually straightforward. You can see there's evidence of negative pressure, conductive hearing loss, type BC tympanograms, and you can see some pathology of variable degrees in the eustachian tube endoscopy. That's obstructive eustachian tube dysfunction. Now, what if they have a normal tympanogram? Well, if they're still having a consistent history of baro challenge, and you see pathology on endoscopy, but it's just lesser degree, that's obstructive eustachian tube dysfunction, just a lesser degree on that spectrum. Now, when you ask about autophony, they may admit to that. You can see those tympanic membrane excursions with the ipsilateral nasal breathing that I showed you. These are the patients who typically are going to have the popping and clicking, not the obstructive patients. Now, but watch out for this group where they come in looking retracted. They may even have an effusion, but they're sniffing. They're sniffing inappropriately. If you've got negative pressure in your middle ear, you shouldn't be sniffing because that's going to make it worse. So you ask why they're sniffing, and they'll tell you, well, it unblocks my ear. What they actually are talking about is it's getting rid of their autophony. These inappropriate sniffers, what we used to call habitual sniffers, they usually have a patchless eustachian tube, and this is how they're correcting their symptoms with sniffing so strongly it can look like obstructive eustachian tube dysfunction, and this is how they can fool us. So you really have to have a high index of suspicion and ask about autophony in all of these patients. Now, if they have no eustachian tube symptoms whatsoever, and they've had a grommet or tube, it hasn't helped. These are usually some other diagnosis, most commonly temporomandibular disorders, and it's usually not the joint. It's usually the muscles of mastication that are tense in spasms, causing pain, fullness, fluid sensation. They pop and they click. So watch out for those. If you balloon dilate them and they don't have pathology, you can actually make them patulous. Minor syndrome, semicircular canal dehiscence, inner ear hydrops, they have oral fullness symptoms with a lot of other inner ear issues, and migraines can also cause this. A good test for patulous is the tympanogram on a reflex decay mode, which increases your sensitivity if you're not adequately seeing the excursions with your otoscopy. Now, once you've diagnosed the obstructive or patulous eustachian tube dysfunction, let's try to get to the bottom of it. One of the most common causes for chronic disease is allergic disease. And here we see numerous studies showing a very high prevalence of allergic disease in patients with middle ear effusions. That doesn't necessarily mean it's causal. Now, if you do skin prick testing, you will pick up a significant number of allergens that could be influential. But even more sensitive are the intradermal testing. And you can see here in this study how the intradermal testing picked up far more allergens than these other common skin prick tests. So if you have a suspicion, but the initial testing, blood tests or skin pricks are coming up negative, you can do intradermal testing, and that can open up the opportunity for treatment with allergy immune therapy. Does it help? Well, in children, it helps even more than in adults. So it can be very effective in relieving otitis media. And here we can see results in children and adults resolving their chronic middle ear effusions and chronic eustachian tube dysfunction. So you want to evaluate, we do a lot of allergy evaluations for this reason. So I'd like to show you a case here. This is a 48-year-old male with persistent middle ear effusion, lifelong allergic rhinitis. 10 years ago had upper respiratory infection and started developing recurrent middle ear effusions and required tympanostomy tubes now 5 times. Allergy testings were negative, and these are the retracted tympanic membranes. Middle ear effusion, even starting to collect squamous debris going on toward a cholesteatoma. Conductive hearing loss as expected, but look at these negative pressures, minus 475, minus 570. This is extreme negative pressure. Now, we've been taught that when you get to minus 400 or above, you should fill the middle ear with a transudate and have a flat tympanogram. So how do you get extreme measurable negative pressures? That's a red flag right there. So what's going on here? Let's take a look at this endoscopy. Here's the right side. This is a fiber optic scope, and we see the torus here looks quite healthy. We're not seeing cobblestoning. The mucosal folds are sharp. There's no edema. So let's angle the scope into the lumen. We're not seeing pathology here in the lumen. There's a little light reflex on some mucus there. So I'm going to maneuver the scope even closer so we can really look at both walls, membranous wall, torus tubarius. And we see that little bit of light reflex. There's no bulge here like you would normally see in the membranous wall. So here's the patient doing a swallow and a yawn. And after that yawn, we see persistence of opening of the valve. This is a patulous eustachian tube. And again, you can see excursions of the tympanic membrane when that valve is open. This is how they fool us. This patient has been sniffing heavily to control their patulous symptoms to the point of causing severe retraction in middle ear effusions. So patulous eustachian tube is far more common than we thought. So we have to ask about autophony. They can have fullness. They may have had past eustachian tube obstructive dysfunction. Their otoscopy can be normal or it can show negative pressure if they're sniffing. And I've shown you how to look at the tympanic membrane. The endoscopy, you may see inflammation at the orifice, like we saw on that previous video, but you can see patches of atrophy in the valve. So you can be deceived if you only look at the torus and the orifice. You have to look deeper into the valve to really see the true pathology in the situation. All of these are patulous eustachian tubes. 30% of our series of patulous tubes look like this. They have evidence of chronic ear disease, even to the point of severe retraction with developing cholesteatoma. Here's an actual cholesteatoma. This patient's been operated for cholesteatoma. You can see excursions of the tympanic membrane there with their breathing. Tympanosclerosis. This is how they fool us. They can look like chronic ear disease. So you have to ask about autophony. Watch out for that inappropriate sniffing. And those patients who are complaining a lot about popping and clicking, think about patulous. Now, we've been taught that weight loss is the most common comorbidity. It's actually environmental allergy in our series, 50%. Weight loss came in at about a third. Reflux, another cause of chronic inflammation. Stress and anxiety. These patients likely have temporomandibular disorders. The medial pterygoid muscle may serve as an auxiliary dilator of the eustachian tube valve. And if these patients are tense and clenching, they can force their eustachian tubes into a patulous configuration. And they get into a vicious cycle of increased stress because of the patulous symptoms. So we have a clinical consensus statement from the American Academy of Otolaryngology, head and neck surgery, on indications for balloon dilation of the eustachian tube. And they're based on the things that we've just discussed. Indications typically, particularly for adults, would be chronic, persistent disease, 3 months or more. They may have middle ear effusion or atelectasis, negative pressure, type B or C tympanograms, and you can see pathology on the endoscopy. That's what you're going to be treating. Now, if they only have baro challenge complaints, you should still see pathology in the eustachian tube that you're going to be treating. So we've talked about this comprehensive evaluation, and a great study by Smith and others showed the importance of that comprehensive evaluation because there's no single test that's valid for adequately assessing eustachian tube function. And until recently, tubal manometry has been available in Europe, but that's recently become withdrawn. And so substitutes are being sought. But for now, we can continue, if you have one, for now, we can continue with this comprehensive evaluation that we've talked about, and we rely a lot on the tympanometry and the nasal endoscopy, along with those patient-reported symptom scores. Now, the symptom scores are not for diagnosis. They cannot tell the difference from any other cause of aural fullness. They can't tell you if you're patchless or tympanomandibular disorders. They're great for assessing before and after treatment. So the eustachian tube dysfunction questionnaire, 7 questions, or the similar patient reported symptom scores. Once you've identified obstructive disease, it's usually inflammation. You know how to look for all the causes of inflammation. You want to treat those. Many of these patients will get better with medical treatment, whatever the cause. Allergic disease, reflux, rhinosinusitis, and others. Important to be sure that you understand the particular specifics of the balloon dilation catheter that you're using. Professor Sudhoff can talk about this more, but you want to be sure that your catheter does not enter into the bony portion of the eustachian tube, and keep in mind the variable lengths in the children that I showed you earlier. If a tube or grommet does not help, remember it's likely another cause that would not be suitable for a balloon dilation. So in conclusion, a comprehensive evaluation of eustachian tube disorders is important. You need to sort out obstructive dysfunction versus patchless, and to recognize those patients who may be going back and forth on that spectrum and treat them appropriately. Certainly if someone has had episodes of patchless eustachian tube, I would be much less likely about doing a balloon dilation or perhaps reducing the time. That comprehensive evaluation, history, otoscopy, audiometry, tympanometry, and that all-important dynamic nasal endoscopy if you're able. Now, as you think about dilation for younger children, the types of pathology can be different. In the under 5 years of age, there can be reflux of nasopharyngeal contents, pathogens, bacteria, viruses, and stomach contents causing inflammation. Whereas in the older 5, there's a high prevalence of allergic disease, and that runs all the way up into adults. So keep in mind what underlying etiologies may be present, and you'll want to maintain treatment for those things even after balloon dilations. So try to identify the causes of inflammation and treat them. Those patients who are refractory to treatment are great surgical candidates. Become familiar with both walls, the cartilaginous wall, the membranous wall. That's going to be all important for your evaluation of the pathology in the valve and your decisions for management. And please keep in mind that a patchless eustachian tube is far more common than we thought. Be on the lookout for it, and you'll be surprised how common that is. So I'll conclude my comments there. Thank you very, very much for this opportunity once again. I'm going to pass you on now to Professor Sudhoff. I'm looking very much forward to speaking with you later about our question and answer time. So thank you very much.
Well, dear Dennis, dear colleagues, ladies and gentlemen in the webinar, I hope you can understand me. Maybe just give me a little sign that everything is in order. And I'm very grateful to my long-term colleague and friend, Dennis POE, for giving this outstanding lecture and getting insight into his knowledge. And along with our group, he pioneered this technique. And it's really amazing what we could find out over the years after we both have started with balloon dilation in 2008. So I would like to focus now. There may be some redundancy in my presentation, but I would like to focus on balloon dilation, eustachian tuboplasty, its application, its safety, efficacy, and long-term results. So just to give you a short idea about balloon dilation. So I hope that I can actually show you very shortly about my department that is located in Bielefeld in Germany. And you can see it's here on the map, which is in between Hanover and the Ruhr area in the western northern part of Germany. It's a very posh city with a historical city center, which is here depicted on the right hand. And our new medical school has been established 2 years ago. And we're hosting 23,000 students in all different kind of specialties. So as Dennis already described in its outstanding presentation, we distinguish a cartilaginous and a bony part of the eustachian tube. And all regulations, and I think that's really important, and that was really shown very nicely, is all the muscles that open the eustachian tube are attached to the cartilaginous portion. So there are, you can see the cartilage, the elastic cartilage of the eustachian tube. You are able to identify all the different muscles that are attached to the eustachian tube, and the regulation is highly regulated and complex. And we have a couple of problems that we actually face while dealing with eustachian tube problems. And looking at the evidence base of eustachian tube dysfunction, we need to define what's eustachian tube dysfunction. I'm going to show you some of the results that we found out earlier. There are many underlying pathologies. There are allergies, there's reflux, there's chronic rhinosinusitis, there's probably Th2 reaction towards eustachian tube dysfunction as well. And the problems that we face currently, there are a lot of different tests. Each measure a different and distinct part of the eustachian tube function, but none of them really gives us a clear-cut idea about the underlying pathology. And Dennis and me and a couple of other colleagues around the world try to establish a better source for data to be able to stratify our patients. So, as Dennis mentioned earlier, what is the eustachian tube dysfunction? And I think if we have an underlying pathology lasting longer than 3 months, we can differentiate an acute from a chronic eustachian tube dysfunction. And we met a while ago in 2015 in Amsterdam, and we tried to come up with definitions, types, clinical presentation, diagnosis. And since then, we have been on a long learning curve looking at different pathologies. And I think we've seen that already. We can have a dilatory eustachian tube dysfunction that can be either functional, where all the muscles attached to the eustachian tube are not able to unblock the eustachian tube while swallowing. There is a dynamic dysfunction. Think about patients with cleft palates and an anatomical obstruction. However, looking at all the experience we have gathered over the years, this is a pretty rare condition. I've seen that in cases of osteopetrosis of the temporal bone or after temporal bone fractures in the bony portion. However, this is a really rare condition. And looking into other pathologies, we see a Barrett challenge-induced eustachian tube dysfunction if you are exposed to different ambient pressures, or a Petelius eustachian tube dysfunction, then can be either chronic, intermittent, or masked. It's very important not to dilate a patient with a balloon that has a Petelius eustachian tube dysfunction, because then we have a high risk to make the condition worse for the patient. If we have a chronic underlying eustachian tube dysfunction, that can be masked. And our colleague Kobayashi from Tohoku University in Sendai, he described that because any bone conduction can be sufficient to mask Petelius eustachian tube dysfunction. And very importantly, and I think we need to stress that, I think the prevalence of Petelius eustachian tube dysfunction, at least in the US, is about 6% of all the patient population that have an impact on the eustachian tube. So it's very important to notice that. and it can be intermittent or combined, and I think you are pretty much aware of that. So how this actually leads to the question, how do we evaluate eustachian tube dysfunction? And I just want to show you some conflicting data that we need to be aware of, because a lot of reports have been based on the EDTQ7 established by McCool and colleagues, who tried to use a simple, clear-cut questionnaire. But I just want to show you this paper looking in a review in laryngoscope investigative otolaryngology for identifying obstructive eustachian tube dysfunction with a systematic review that has been published recently and trying to look at the risk. It will be really great to have a very simple assessment as depicted here. You can see high risk, the studies with a bias in sensitivity and specificity, and taken from this systematic review by Anderson and colleagues. But I would like to show you another paper that has been published by Emilio Commesso recently in the laryngoscope. And this is very important because it would be great to have, and we're currently working on that with a couple of colleagues, looking at the screening method that is really easy, where we can actually depict patient. But you need to be aware that there is no clear-cut questionnaire at the moment. So looking at this paper, they were unable to differentiate between eustachian tube dysfunction and non-eustachian tube dysfunction patients. So this is actually not a good tool from what we know at the moment, and we need to work on that to get the indications for our treatment right. So you've seen that paper. The majority of the patients that we treat have a normal tympanic membrane appearance on the left with the eustachian tube dysfunction. So it's very difficult to conclude from any otoscopic picture to see if there is there an underlying eustachian tube dysfunction or not. Of course, in children we see otitis media with effusion, or more in adults we see retractions that are going to have an impact on middle ear function. It's very, very important to do an endoscopy of the eustachian tube, to look at, to do an endoscopy, and you will be amazed how many different pathologies you can find. This is showing you on the left superior picture scars after the adenectomy, there's cysts, and on the lower left you can see cobblestone pattern that is due to reflux. And even if you have severe reflux, you have a mucosal damage that can lead to scar formation, and you will find this very typical cobblestone pattern of the mucosa that is an indicator for hyperplastic mucosa. Always think about the box. Look at other pathologies you can find, and I just want to entertain you a little bit. Be aware of dogs licking ears. So sometimes you get bacteria that are going to have an impact on the function either of the external ear or the eustachian tube, where you wouldn't expect that to be. So always you need to work and to look a little bit outside the box to deal with this subject, because it's really exciting. One thing that we see very frequently, and of course this is pretty clear cut, so in patients with chronic rhinosinusitis with or without polyps, we are looking at a Th2 reaction of the mucosa, and the most important cytokines are interleukin 4, 5, and 13. And of course, if you have this pus, you get a hyperplastic reaction of the mucosa, and secondarily, you will have an impact on the eustachian tube function. So be aware that there are possible problems that have an impact on the eustachian tube that are derived from the sinuses. And what we have seen with the use of biologic like Dupixent, what we see is an impact on the eustachian tube function that will lead to an improvement of the eustachian tube. So besides that, besides balloon or injecting soft tissue fillers into the eustachian tube in cases of peteneus eustachian tube, you need to be aware that sometimes you need to think about a conservative treatment, and biologics may be another aspect to go for. So again, you can see this kind of morphology. On the gross morphology, you see the cobblestone pattern, you see an impact, a hyperplasia of the superior portion of the mucosa of the eustachian tube office. So this will for sure have an impact on its function. And you always have to ask the patient to swallow, and then you can see the direct impact just by gross morphology. However, you can't rely 100% just on the gross appearance of the eustachian tube. If you take biopsies, you can see this cobblestone pattern. You can see the high degree of inflammation of the subepithelial connective tissue, leading to an edema, leading to a dead block situation of the eustachian tube. And it's sometimes amazing if you take repeated biopsies about the degree of inflammation. So sometimes it's looking even a little bit more weird, and histology is helping us in a couple of cases. So besides the adenoid, sometimes you see pathologies with a localized amyloidosis. I just want to show you this picture very briefly, where you have this kind of yellowish impact on the gross appearance of the outer appearance of the eustachian tube. And on biopsies, what you can see is HE staining, and on polarization and congruent staining, you are able to identify the amyloid. This patient had a long-term history of single-sided middle ear fusions, and so you need to consider that as well. So let me just very briefly talk to you through the procedure. There are different distributors around the world, but I'm just wanting to show you the equipment that I'm most familiar with is the introduction device, where the rear of the insertion device is loaded with a catheter, and there are different angulated pieces that are attached to the insertion device that are differently angulated. Normally, I would prefer 70-degree attachment device for the procedure. What's important when you prepare the patients, normally we do that in general anesthesia. However, we are able to do that in a local anesthesia as well. So this is the operating table where you have cotton swabs that are soaked with xylomethicillin so that you can decongest the nose prior to the balloon dilation. There's a pressure syringe on the table, and you can see the different angulated endoscopes on the table and the different attachment devices. So make sure that you have a proper decongestion. Some of my colleagues in the Scandinavian countries use cocaine solution for that as well, because this is going to give you a much better view as well, and quite helpful to prepare the patient prior to the procedure. The procedure itself is pretty straightforward. So you look at the office of the eustachian tube, you puncture it, then you introduce the balloon via the insertion device, and then you need to, I push it in very gently, never against any resistance, and then you are able to push it in completely. Make sure that you don't reach the bony office or the middle ear spaces, and then you dilate it for 2 minutes at 10 bars. It's very important not to retract the balloon in an inflated stage, because you may lower the pressure in the middle ear. So I think there's a potential risk that you would like to avoid. It's not always easy and not always as straightforward, especially not in children, and I'm going to talk about that pretty soon. So looking into the pathology, I just need to, what you see is that the insertion device is entering the orifice of the eustachian tube. The balloon is pushed, reaching the isthmus region, that is the most critical region for balloon dilation, without any resistance and without tilting. And then the balloon is filled with saline or water, and you can see it in an inflated stage. Make sure that you don't push the insertion device in too deeply. You can see the deflated balloon here, and there are different kind of balloons. There are compliant and non-compliant balloons, and this is a non-compliant balloon that is changing its width with the pressure inside. So it will go from 3 to 3.3 millimeters in width. That is generally, to our experience, sufficient enough to clear the situation. So what I prefer, and what I've done this morning, is a contralateral approach in adult patients. And here you can see the insertion of the Hopkins optic, 70-degree angulated, and the insertion device on the contralateral nose. Sometimes if you have severe septal deviations, it may be possible to do it. If you don't have severe septal deviations, it can be possible to use one nostril for the insertion in adult patients. However, I prefer to do that via the contralateral approach, which is, I think, most favorable, at least in my hands and in the experience of our team. Sometimes it's helpful, especially if you want to do eustachian tube surgery, and I will give you an example later on, that you have a symmetry, that you do a velotraction, you take a 70-degree Hopkins optic, and you put it via an oropharyngeal approach, that you are able to depict the posterior portion of the nose, the choana, the septum, and you have the symmetry of both eustachian tubes. And here you can see the insertion of the device. Here's a Tornmold cyst. So this is helpful, especially if you want to recanalize eustachian tube. I'm going to show you a couple of pictures of that later on. So initially, when we started with that, we looked at a cohort, and I just want to give you a little bit about the evidence of a balloon dilation with different devices and different techniques over time, to look at the long-term effects of balloon eustachian tuboplasty. And then the papers that we published in 2015, looking at tubonometry score called ETS5. And this is a tool that's unfortunately taken from the market, from the French company producing that, but it helped us to define a cutoff level to look at the effects of balloon dilation in those patients. And you can see an improvement 2 months after balloon dilation, 1 year, 2 years, and even 3 years after the procedure in 622 cases, but we had a significant dropout rate in this patient because initially we got patients from all over Germany to treat this condition. So then Dennis, Ted Meyer's group came up from South Carolina, from Charleston, with a group looking at randomized controlled trials of balloon dilation for persistent eustachian tube dysfunction, 1-year follow-up. And Ted Meyer's group concluded, and they published that in Otology Neurotology in 2018, that balloon dilation is superior to continued medical management for persistent eustachian tube dilation. So one point to look into that. What other randomized controlled studies are around? And there is another group by Anand, balloon dilation of the eustachian tube 12-month follow-up of a randomized controlled trial treatment group. And they actually showed that there is a beneficial effect of balloon dilation in patients with refractory eustachian tube dysfunction, and there was a durable, a long-term effect after 52 weeks of follow-up. So we have another randomized control study along that Dennis Poe performed in Boston along with his colleagues from around the US, looking that he published in Laryngoscope 2017. And this further study, adding on our information on balloon dilation efficacy, showed that the eustachian tube balloon dilation is superior to the medical management of chronic dilatory eustachian tube dysfunction in adults. So this is very important information. But in adults, and I see that as a continuum of disease. So you start with maybe acute otitis media in early childhood, you get chronic secretory otitis media during childhood, and then you develop further more severe middle ear disease like retractions, like cholesteatoma, like other diseases that are related to eustachian tube dysfunction. And so I think it makes sense from a perspective of disease control to do a procedure in children as early as possible once you are able to identify that. However, this condition of secretory otitis media is very common, and at least 90% of children in the US and Europe are affected by that. And again, what you can do, and we just dared that after a while to do our first cases in the pediatric population, again with a contralateral, ipsilateral, or pharyngeal approach. And I particularly like the pharyngeal approach very much in children because it gives you a really good overview when you apply the procedure in pediatric patients. So we came up with a paper very early. My colleague Matthias Tisch from the Ulm Armed Forces Hospital published that along with our group in 2017, looking at 126 children, where we found that balloon dilation, and you need to know that all these children had at least 2 grommets being inserted. So it's a highly selected, really patient cohort with a bad condition of the middle ear, and they responded pretty well to balloon dilation of the eustachian tube, better than the previous management. So then Matthias and a couple of other colleagues like Sarah Alteneuer and the Heidelberg group and Frankfurt, we just tried to collect all our data in a retrospective multi-center analysis. So this is, I think, the largest cohort in patients, in pediatric patients in Germany. And I would like to show you these data. We had 285 patients included with the error bars here. And you can see the data. All patients BET only, BET plus, before and after treatment, and the healing threshold as an objective measurement. And this is showing you a significant improvement with the addition of balloon dilation. And so I think these results were very promising to look at the patient. However, I think there are so far no randomized prospective controls at the moment in prospective controls in children. So what we found out looking at all our collected data in children so far is that BET is a promising treatment for dilatory eustachian tube dysfunction in children. It's safe and effective as a second-line treatment, and we looked at children from the cohort of the age of 4 and older. There was a significant treatment effect observed on automicroscopy, screening thresholds, and tympanometry. So tympanometry is not a good indicator for eustachian tube dysfunction per se. And this study, I think, gave really good overview and pilot data for prospective pilot study, and I think we need to establish that to have more data on a higher level of significance. Just want to give you very shortly an idea how difficult balloon dilation can be in children. And even in younger children, you have, of course, I wouldn't recommend that as a first-line treatment at the moment. But what you see, if you can see the office of the eustachian tube here, and interestingly, if you dilate the balloon and you are in the correct position, what you get is contractions of the soft palate due to a stimulus by pressure. But here you can see an old adenoidectomy scar in the nasopharynx. You can see the device being inserted, but it can be really tricky. And if you look at the right picture, sometimes you can use the insertion device as a tool that you can palpate and that you can visualize of the office of the eustachian tube to get the catheter into the right position. Don't do an adenoidectomy before. I just want to show you that picture. So you get a lot of bleeding, and that actually can obstruct your vision much to a really bad degree that you are able not to identify the office of the eustachian tube. So you either do the balloon first or you do it sequentially in order to have the best possible outcome for the patient. So if we use a balloon, and I will focus now on the complications of balloon dilation, because each procedure has its own difficulties and its own complications. And my colleague and friend, our radiologist, Björn Gehl, he actually allowed me to put this sheep skull under his CT scanner at night. So we did these pictures, and initially it was quite difficult to develop a pressure model of balloon dilation because we are unaware about the pressure changes in the middle and inner ear. So this is the bony skull of a sheep, and you can see the bulla, the cochlear, and then at the very back of the nasopharynx, you find a small valve. And I just want to show you this picture showing you the cartilaginous portion of the eustachian tube, a balloon being introduced into the eustachian tube. And my co-worker Ingo Todd, he had the really great idea to put a pressure sensor into the middle ear of this model, and then that was sealed with fibrin glue. And then you can see the lower curve here where you introduce the balloon, the pressure is increasing, and with the balloon dilation, you get another pressure peak. And then when you withdraw the balloon, you can, if you do that in an inflated stage, you will get a significant negative pressure. So I just can't recommend that. And this is the pressure probe that was introduced by him. So looking at the different models, if you look at force per square area, you can see these values if you release the balloon, if you inflate the balloon. And we looked into that and we couldn't identify a risk for the round window break, a membrane break, Rhizome membrane break, or even tympanic membrane rupture. However, I just want to show you one case that actually was a little bit annoying. So looking into problems, and I want to share that case with you because this 14-year-old male Caucasian patient got an adenoidectomy at the age of 1, a revision adenoidectomy at the age of 2, and a tympanoplasty for cholesteatoma at the age of 3. And then there were 9 revision surgeries of the middle ear being performed. And the boy always complained about negative pressure. And Dennis kindly showed you the changes in the middle ear pressure over time when you don't swallow from Rostock University. And what you can see here is there was no opening of the eustachian tube at all. So this was the prosthesis when I did revision number 10. You can see how the prosthesis and the head of the prosthesis was bent. And that was done by a really good middle ear surgeon from Düsseldorf. And what you could see is, would assume that he never put prosthesis in like that. So the negative pressure can develop pretty extremely, and this titanium prosthesis was completely bent. So adnodectomy with a Beckman's ring curette. I know that there are different techniques around the world, but with the Beckman ring curette, you induce scars, and you can see them here in the middle portion of this boy. There was the office of the right eustachian tube was severely damaged, but there was no opening of the eustachian tube on the left. So how do we deal with that condition? How can we get along with that? And I just want to show you another case example of she is an ENT nurse working in an ENT hospital, and you can see the scarring. She got an adenectomy at the age of 3 years. You can see the scarring, and then I reopened that using a true blue laser, and you can see the opening of the eustachian tube, and it's really amazing. If you open that, what you see is a glue eustachian tube, and the symmetry, again, I did an approach via the oropharynx, and you can see that the mucus from the eustachian tube is actually released like if you would do a myringotomy in a glue ear. The hearing of that patient came back to normal. But how, and this is more important and more difficult, how can you keep it patent? Because if you use lasers, and especially in the circumferential scar, it's quite risky. So what we did is I put in a balloon catheter. You can see the cartilage palisades here in her tympanic membrane. And that was done in the anterior portion. And you can actually put the catheter inside the eustachian tube from the external ear canal, and then you push it forward till you see the peak of the very tip of the balloon catheter, and then we fixed it and we left it in for 6 weeks, and that was actually sufficient. And you can see that after the removal of the balloon catheter, this lady was able to do a Valsalva maneuver. Here is a little bubble, and a little bit, it's not very professional, but I think we need to look into a kind of stance that we can place there in order to keep the eustachian tube open. Because if you don't put anything in, you will get a reblockage of the eustachian tube by scar formation. There are complications, and we published that paper in 2018 with my colleague Götz Leonard, Sarah, and Carsten, and from Wuppertal. And you can see what you get if you tilt the balloon, if you get some kinking, and then you still inflate it, or if you do any mucosal injuries. And you can see this air being entrapped, this emphysema of the soft palate of the cheek. And if you are really unlucky and the patient will do a Valsalva maneuver in the recovery room, we had one really bad case where you can see the emphysema in the mediastinum, and we don't want to have this condition. So make sure once you use balloon that you put it in gently, that you don't inflate it against any pressure, and that the balloon is not injured the mucosa. I think that's a very unlikely situation, but we had in total as a group, we had about 6 cases of that. We had another 7 cases of hearing deterioration. And one case that I'm going to show you later on that really frightened me a little bit. But what you can see is the pre and post-op hearing threshold. And we had one case, we had this loss of hearing in 7 cases out of a huge number of almost 6,000 patients in our cohort. So this is a pretty rare condition, but make sure if it's critical that you do at least a little puncture to the tympanic membrane in cases where there is where you're going to increase the pressure too significantly. This was a case where there was an expert witness from a different hospital outside Germany. What you can see here is air being entrapped into the vestibule. So this patient, who was unfortunately a professional singer, he received balloon dilation, and for whatever reason that is not really well understood, he got a dead ear after balloon dilation. This is the only single case I'm really aware of that, where you can see air in the vestibule, and this was a medico-legal case where I had to report on this case. But this is very, very rare. So the next case I would like to show to you, which is very important in terms of inclusion criteria. This is a Petlius eustachian tube. You can see this very typical breathing excursions of the left tympanic membrane. Make sure that you use a reflex decay. This is the best instrument, and I think looking at the differential diagnosis, what Dennis mentioned already. Don't look at the temporomandibular joint. Is there a minus syndrome? Is there a superior canal dehiscence syndrome? Is there any other pathology to look at? So make sure that you don't miss that. If you dilate patients with a Petlius eustachian tube, you can only make it worse. So this technique is very important to look into. I just want to show you very briefly a technique that we developed for Petlius eustachian tube recently, and which is, at least in our hands, I had my first revision case now. But what I do, and it's very important, normally patients don't report on problems if they lay down flat. The problem is if we do surgery in an anesthetized patient, we really are looking at a patient in general anesthesia or that doesn't have any symptoms of a Petlius eustachian tube while being in that position. Please remember that you can only see a Petlius eustachian tube on a CT if you do a cone beam CT in a standing position. So the patient, and these are pictures, these are no photos, of a patient that I treated in local anesthesia, we can inject into the office of the eustachian tube a polymer that's going to block parts of the eustachian tube. And the good thing about doing that in local anesthesia is really that you have a direct feedback mechanism. So you can ask the patients, are your symptoms gone? And I could discharge a patient today who was seen for a couple of years by a psychiatrist with a Petlius eustachian tube, was on medication because he couldn't stand that. And when I saw my colleague discharged him, or was talking to him on the ward rounds yesterday, he almost squeezed him, and he was so happy and delighted. And just remember, if you do that in local, you can ask the patients, are your symptoms of a Petlius eustachian tube gone? And can you continue? And you get a direct feedback. So this technique, I think, is really quite good because you can actually work with the patient's response and considering the feedback, because there is no clear-cut volume that you can inject. Probably it's about 1 milliliters, but it may vary from case to case. So just very shortly showing you the site of injection, and it's quite helpful to inject that and ask the patient about the relief of the symptoms. So looking at to our experience in terms of long terms, I've discussed safety and efficacy of balloon dilation with you. what is the overall experience looking at our patient cohort, looking at the rate of improvement over time? And I think if we are confronted with a patient having short-term symptoms like ambient pressure problems or bowel challenge, eustachian tube dysfunction, this is actually quite good to get a really outstanding outcome in those patients. And I think Saku from Finland, he actually found that as well, looking into divers and flight personnel. He was able to look at a large cohort from flight staff, and he could see that very significantly, and he did a really great study in divers as well. The inability of a salvo maneuver, along with the middle ear pathology, is a good indication, but be aware that 2% of the general population can't do a salvo maneuver and will never suffer from middle ear problems. So you need to investigate those patients really properly. Chronic otitis media with diffusion is a good indication, especially in children. However, if we face more severe middle ear conditions like middle ear atelectasis or recurrent middle ear disease, or even protruding middle ear prosthesis, this condition is much more difficult to clear, and the success rate in this patient group is not as significantly good as in this group, where you just have small changes to the middle ear. So it's a continuum. We need to clear that. And our success rate is, of course, dependent on the duration and the severeness of the underlying pathology. So far, just very briefly, I would like to show you our results after 15 years. We haven't seen any severe side effects in our patient cohort. We had 2 balloon ruptures with pinhole defects of the balloon where we syringed the field without any negative outcome. We had minor tinnitus enhancement, probably of the patients with a really significant hearing improvement. We had 7 cases of temporary hearing loss, 1 dead ear where was an expert witness on a medical legal case that was done in a different country, and 1 Petrus eustachian tube that we created probably, but that's the only case I'm really aware of, that because we do the stratification of our patients really carefully. We had about 300 revisions and 6 emphysemas. So looking at this large group of patients that we overlook at the moment, from the age rate range of 1 to 86 years, I think it can be concluded that the technique is safe and not causing significant damage to the patients, apart from very, very rare cases. So to conclude my presentation, I would like to supply you with some of the references from our group of over the years. We started in 2007 and 2008 with that technique. So there was a really good learning curve. And to conclude my presentation, I would like to thank you for your kind attention. I would like to appreciate my group who helped me within Bielefeld, my long-lasting friendship with Dennis Poe and the group in Cambridge. And so I'm very much looking forward to taking your questions. Thank you for your kind attention.
All right. Well, thank you, Professor Poe, and thank you, Professor Sudhoff, for these 2 really nice, excellent presentations. In particular, I liked and appreciate how deep you dived into this field and how much information you shared about this whole area. So it has been extremely interesting. But nevertheless, we did receive a whole bunch of questions, which is why I would already like to hand over to my colleague, John, who will open the open discussion around and address all questions that he has collected and received over the past 80 minutes. So, John, I would like to hand over the microphone to you.
Sure. Well, thank you very much, Professor Sudhoff, and thank you very much, Professor POE, for your presentations. Yes, there were some questions written here on the chat while you were presenting, and apart from that, I have also collected some questions from our colleague Martin Koch, who is in Rome at the moment, and he is attending an event which has been organized by Desde Hospital, our distributor in Italy, and the event is on BET, and the Professor Giuseppe Maiulo, sorry, from Sapienza University Hospitals, and we have also some questions from them. So I'm going to start with one of the first questions that we received on the chat, and is whether there's any change or any difference when you choose for a scope, when you are going to treat a patient, which an adult or on a child, sorry. Different size of. I would like. Sorry, the question is addressed to both of you. So, if I would like to also initiate an open discussion amongst the both of you, please.
Helger, would you like to proceed with that? You've done far more children.
I think, but I will do, Dennis. So what I see is actually we use the same kind of device. And if you look at the ossification of the temporal bone, the different angulation of the eustachian tube, I think looking at the device that we currently use, well, I think there is no necessity to change because, of course, if you look at pediatric patients, the length of the eustachian tube probably is finalized at the age of 7 to 8 years. And of course, the part of the bony eustachian tube is increasing over time. So it's 9/10 of the eustachian tube in pediatric patients are cartilaginous and 1/10 is bony. So the balloon is sufficient in the design that we currently use. However, we don't have any prospective randomized controls at the moment, so we need to have them. We need to look more carefully into that subject. But from our experience, we didn't see any severe side effects. Of course, the angulation is different. Dennis mentioned that already, that you have a more horizontal position of the eustachian tube. In children, you need to consider that. But this is currently the experience that we in Bielefeld use, and I think in most centers in Germany, that we use the same device for the balloon dilation in pediatric patients.
Thank you. Regarding the endoscopes, in the office, if the child is old enough, I do like to try the pediatric endoscopic examination. It's a 2.7 millimeter diameter flexible scope, and that's well tolerated in the children who are cooperative, because I do like to do that dynamic endoscopy, the swallows and the yawns. And we use that pediatric scope in the office up until they're at least 18. Particularly the teenage males are particularly prone to fainting from the endoscopy. In the operating room or theater, the smaller patients, we use the ear endoscopes, the 3 millimeter 45-degree endoscopes give a nice view, almost as good as the 4 millimeter scopes, and I find it fits better and causes less bleeding.
Well, thank you very much for answering that question. Another question that came from Paris, and they were asking about the use of tubomanometry. We've seen that the product is no longer available. How do you perform this assessment how did you evaluate the eustachian tube?
Dennis, if you don't mind, I would ask a question. I'm not sure if you have this device in Boston, but I think it's a really good device. It's really sad that the French supplier of this device stopped the production due to our new legislation for medical devices, and I think we need to find a different solution. It's actually looking into active and passive eustachian tube opening, and and it's a good tool based on the experience we've done, about 50,000 tests. And I think it helps you to stratify the patient. And I would love to see a replacement of this device because it's a good tool. It's not 100% safe, and you still need to do a very careful and thorough exam of the patients. You have to take the history. It's not the only thing you can rely on, but we need scientific data for the follow-up that is objective. And I think this is a device that should be reestablished because it has a potential to be a kind of routine diagnostic device.
Thank you.
A very good study from Matt Smith in Cambridge, and I was privileged to participate in that. It really looked at a comprehensive review of all of the different means for evaluating eustachian tube dysfunction and function. They found a good role for the tubomanometry, and in its absence, we have to substitute all of the other things that we've talked about. So again, reliance on the history, the otoscopic exam, and the tympanometry is still quite valuable, although it doesn't give you the full story. But if you combine those with the endoscopy, you can still get a pretty good impression of what's going on. And the other instrument that they mentioned was the sonotubometry, which is not widely available. It's more commonly used in Japan, but there are a lot of false positives and negatives with that as well. So there is no single test. So yes, we will miss the tubomanometry. I do hope it gets replaced, and I hope one of these days we get it in the States.
Yeah, hopefully, definitely, it will help a lot, and I'm sure that it is now a job of the industry to work on it and have something available. So I'm sure the good companies are working on it. Another question that we received is about if you have any experience with sedation or any other procedure which is not using under general anesthesia for the eustachian tube dilation.
Okay, you can proceed with that. I'm not in a pediatric hospital. I'm not doing them under local anesthesia here.
Yeah, well, I don't have a lot of experience under sedation either. So I was fortunate to be in the cluster of a PhD thesis in Helsinki on local anesthesia and sedation. It's possible, and I think in Denmark and in a lot of Scandinavian countries, it's and I think Ted Meyer is doing that as well in the States in local anesthesia in adults. Personally, I think it takes more time. We do it as a day case under general anesthesia, and we have a lot of experience with that. Sedation is possible, and I think without any doubts, if the patient is cooperative, we can do that. But most of the cases I've shown and presented here have been done under local anesthesia.
So
And general anesthesia, sorry.
Yeah. So it's quite commonly done under local office anesthesia in the States. The best protocol I've seen is from a chap, Mark Dean in Texas. And I've watched him do it quite comfortably for the patients. So it's a progressive application of tetracaine in the nasal cavity, and then he applies what's available in Europe called Pilocream. It's tetracaine lidocaine cream. He will inject a little bit of that into the orifice, and he leaves all of these for several, perhaps 10 minutes at a time, changes the pledgets with the tetracaine in the nose, and without any injections, he can do a balloon dilation quite comfortably. So I've seen that. Word of caution, when you blow up the balloon, you can get a baro response, a profound vasovagal response if you blow it up too quickly, so no faster than 1 atmosphere per second. Since we've done that, I've not seen that. We've seen that in general anesthesia as well. So slow insertion, and very slow insertion, very slow inflation of the balloon, and you can do this comfortably in the selected patients.
Okay, thank you. Another question that we received is, in your opinion, does the eustachian tube dilatation help reduce or prevent cholesteatoma formation by offering long-term effective middle ear ventilation for obstructive eustachian tube dysfunction patients? Any?
So again, I don't know, Helge, would you like to take it first?
Well, I don't mind, but I think to our experience, this is a very difficult question to answer, because a study design, you would need to actually have a really good answer to that question, which we all hope that we're going to prevent cholesteatoma. And as we all know, there are different underlying pathologies for the pathogenesis of acquired cholesteatoma. But I think looking into that, there is a likeness for that, and that's why we do that, partly as kind of preventive surgery, but we don't have any long-term results. So the study design would be like applying that in children very early in their otologic career of middle ear pathologies, and to see in the long term in those cohorts if the incidence of cholesteatoma is going to decrease. So at the moment, it's quite likely that we have the sequence of retraction, the proliferative stage of the retraction, and then the active attic cholesteatoma. And we hope that we can prevent that. But so far, we don't have any scientific evidence that we are able to prevent. We hope that we do it, and it's likely. But I haven't seen any study looking at that we can actually lower the incidence of cholesteatomas in those patients.
So we do know that grommets, tympanostomy tubes, significantly reduced the incidence of cholesteatomas, and you would hope that the balloon dilation will accomplish similar results in place of tubes or grommets. There are, I completely agree, there are different etiologies for cholesteatoma. It's not going to help the perforation where skin has migrated into the middle ear through the perforation. So where it will help is the patients who have a retraction pocket, it's not yet fixed, and you want to prevent it from becoming fixed, or it has been fixed and you've released the fix, placed a cartilage graft, and you want to prevent it from happening again. So I'm commonly asked, should we do a balloon dilation on every cholesteatoma patient? And the answer really is, it's appropriate if they have active obstructive dysfunction. Do they have evidence of negative pressure? Are they baro challenged? Do you see an effusion? Do they have negative pressure on their tympanograms? As I showed, you can have cholesteatoma in patients who have patulous eustachian tubes or normal tubes. So we need to keep in mind that once a tympanic membrane comes in contact with middle ear mucosa, again, this is Jan Grote in the Netherlands work, there's upregulation of inflammatory mediators that can propagate that cholesteatoma regardless of the eustachian tube function at that point. So in assessing each cholesteatoma, if it's a fixed pocket, make sure you do cartilage to prevent a recurrence. And if you see evidence of negative pressure, a balloon certainly could be beneficial.
Yeah. I'm glad you answered that. You mentioned that. Sorry. Go ahead, Professor.
Just to add on that, I wanted to do. I had a patient with a severe retraction where I did a balloon dilation prior to the cartilage tympanoplasty. And when I did the balloon dilation, and then I looked at the tympanic membrane to put in the cartilage graft, it was in its normal position, and it was very easy. I didn't have to it was not fixed, as Dennis said. So I could very easily put in a cartilage graft underneath the tympanic membrane, and it was a really easy procedure to do. So I could see that online, and when I did the otoscopy with a surgical microscope just after balloon dilation, the tympanic membrane was in its normal position, whereas it was completely retracted prior to the procedure. So there is evidence for that, and we see that on the cases that we do on a routine basis, However, we need to look into that with more scientific means.
Good. Okay, thank you. And another question also written on the chat during the presentation was whether it would be recommended to warn, or if you think it would be necessary to recommend or to warn a patient about the risk of a dead ear prior to the dilation.
I would say no. It's now been,
there is no risk.
It's been reported as one out of Professor Sudhoff's 6,000 case experience, whether you've done it worldwide. How many cases do you think have been done worldwide? Probably about 150,000.
Yeah.
And so one reported case.
I think we look almost at about 200,000 cases now worldwide. And I think this is a large sum of cases. And if you look like Klaus Janke from Essen University, he reported about 2 deaths with a Valsalva maneuver in an outpatient basis that he published in the German ENT journal. And so I think looking at the likeliness, it's very, very low. And under normal legal measurements, I think we don't have to do that in terms of legal of medical legal medicine. But just I'm aware of this single case because I was asked from a department in Austria to comment on that case. But I don't want to hide it, and I think it's very important to report on bad results as well. So that's why I got a hold of the scans and I showed that in the presentation. It's a very rare condition, and I think normally we are very, very safe, and I think we shouldn't frighten the patient with that figures in mind.
Yeah, I'm glad the question came up and that you could explain your experience. Sorry, Professor.
Yes, our medical legal standard in the States is generally if it's a 1% incidence of a complication or more, you are obligated to have that in the informed consent. If it's below that, it's really up to the surgeon if you think that's appropriate.
Speaking of cases, I wanted to make a remark that with Spiegelanteis, there are over 120,000 cases performed with the Spiegelanteis balloon. Another question that I also would like to ask you is about the time. How long are the benefits from the balloon dilatation expected to last, and if there are repeat dilations after required?
Okay, would you?
Yeah, well,
you talked about it.
What we see over time, there are patients that are able to, even in the recovery room, are able to do a Valsalva maneuver straight away. But there are some patients that will get an edema after balloon dilation, where it actually becomes worse initially after the procedure, and they will benefit from the procedure a couple of days or weeks later on. And we see a long-term effect of balloon dilation. And Dennis, you worked beautifully on the histology of the proposed mechanisms that you get, that you actually are able to crush the edema with the inflammatory infiltrate, and you get a recovery of the mucosa. We probably shear off part of the biofilm infection. So we see an improvement in the long term in the majority of patients. And of course, if you have an underlying persistent pathology like reflux and you don't treat that medically, I think you can have a recurrent disease. And we've seen that out of 6,000, we had about 300 revisions in our patient cohort.
So the balloon has been shown in our histological study to have actual histological effects from the expansion of the balloon, as Holger just mentioned. And your group has reported that it takes about 4 weeks for the clinical results to really be optimized, 4 to 6 weeks. And we see that as well clinically. So I caution people who have a balloon so that they can fly, that they may not be able to fly comfortably immediately afterwards. Now, interestingly, there's a rat study was just published this year from Korea that showed exactly the same type of histological changes. And in fact, the edema from the balloon took about 4 weeks to go away. So we're seeing in both the human and rats that there are similar changes. That it looks as if you had done an adenoidectomy on adenoid-like tissue in the lumen of the eustachian tube. So I think of this as an adenoidectomy in the lumen. And so whatever inflammation you are having to deal with, if there is lateral adenoid bumping against the torus tubarius, interfering with opening, you can remove that endoscopically. Use monopolar cautery. If you've got tubal tonsil tissue, a bulky torus that's interfering with opening, you can trim the medial half toward the adenoid with the monopolar cautery on a light setting. If you see this inflammation in the lumen of the eustachian tube, the balloon, that's what it's designed for. Just like adenoidectomy, you should expect lasting, durable results. And all of the studies that have had more than 2 years of follow-up, Helge, you showed some of those. They've all shown durability of the results. Now, if you don't keep the underlying medical condition under control, for instance, allergic disease, rhinosinusitis, ongoing inflammation can cause a recurrence of the condition. So you don't intend to do a second adenoidectomy, but sometimes we have to if you don't keep the underlying condition under control. I think of it as a very similar situation. In our series, we're about to report about 200 consecutive balloon dilations in adults. And of those, I've done 6 revisions, patients who came out of medical control, and I've had to revise them.
Thank you for your answers. Another question that we received is what adjunct procedures should be considered in conjunction with the balloon dilation of the eustachian tube? Should tympanostomy tubes be placed routinely? And should everyone with a tympanic membrane perforation or cholesteatoma get a balloon dilation? Professor POE?
Right, thank you. Well, the adjunctive procedures should be determined by the surgeon. What do you think is necessary? If the patient has a thin serous effusion, I will likely do at least a myringotomy just to release the negative pressure. Not everyone does that, and we don't actually have good evidence. There's conflicting evidence as to whether that actually helps with the long-term results by relieving the negative pressure early on. I do like to do it because the patient gets an immediate improvement in hearing. If it's a mucoid effusion, I may place a sub-millimeter infant tympanostomy tube and drain the effusion through that. And these tubes will typically come out in under 6 months. Other adjunctive procedures I just mentioned, trimming tubal tonsil tissue, lateral adenoid, turbinates, whatever the surgeon thinks is necessary, and endoscopic sinus surgery. I think of the balloon as an extension of treating inflammatory disease in the upper aerodigestive tract, whatever you think is appropriate to clear the disease.
Well, from my perspective, I completely agree with Dennis. So you need to individualize the surgery. You need to look at the underlying pathology. I think, like in medical school, if the answer is always, it's always wrong. So in cases of all cholesteatomas, I think balloon dilation is not indicated. But if you have a cholesteatoma with an underlying eustachian tube pathology that can either be petuous or dilatory eustachian tube dysfunction, you should consider treating that. Because a cholesteatoma is just, if you do surgery, you remove the end stage of a disease. You get rid of the squamous epithelium by surgery, but you haven't tackled the underlying disease. And I think sometimes we see those cases, and there is an interdependency. Sometimes I think, and Dennis, we should work on that as well, looking at a primary and secondary eustachian tube dysfunction. Primary as well, the condition of the middle ear is determined by the eustachian tube dysfunction. And secondary, if you have like an implanted cholesteatoma that is releasing a lot of different pro-inflammatory cytokines, I'm sure that you have an impact on the eustachian tube function as well. This may be indistinguishable when we see the patient, but sometimes we operate a cholesteatoma and the eustachian tube function goes back to normal. So I think there is an interdependency because it's a united airway, and we need to look into that much more closely. But I think, as always, if there is 100% is never true. And so we need to work with that, and we need to individualize our surgery.
Helger,
Okay.
you bring up a very good point. It certainly can be done in conjunction with ear surgery as well, tympanoplasty, cholesteatoma surgery. We do it all the time. But you want to do the balloon first, so that if you don't, when you blow up the balloon, you're not going to disrupt your recently placed graft.
Exactly.
May I ask you then, are you typically placing a grommet at the time you do a balloon in children?
No, I think we want to get rid of the grommet, because a grommet is not a really nice device for child. It prevents it from swimming, him or her from swimming. And what we do, we just do a simple meningotomy, a very small pinhole into the tympanic membrane, and then I do the balloon dilation, and I try to skip the grommet, because I've seen so many complications especially from long-term T-tubes and grommets, and we at least a significant number of our laryngoplasties are due to grommet insertion, especially long-term in the pediatric group. So I think at the moment we are on a kind of development towards favorable results for balloon dilation. But I think the goal is to reconstitute normality of the eustachian tube and try to prevent grommets, because grommets can be helpful, but I think we need to reconsider that very carefully in the long term. We still not have enough evidence to come to that conclusion, but I think that would be the future perspective of research looking into that.
Yeah, well, thank you. I want to say I find this time very valuable that you are answering, and we are receiving a lot of questions even while you are answering these prior questions. So another question that, for example, from Peru, we received a question about syndrome patients or Down syndrome patients. Sorry, what is your experience, and would you consider that a contraindication?
Well, so I have done some late teenage or early adult and a couple of middle-aged cleft palate patients with who I saw had inflammatory disease in their eustachian tubes. So I think that's a reasonable, and I did not see a severe evidence of muscular dysfunction. So looking at their endoscopy, some of the older repairs for a cleft would elevate the levator veli palatini muscle so high that it's obstructing the eustachian tube, and a balloon may not help with those patients. But if you see relatively reasonable muscular function, but it's the problem is inflammatory, the balloon could help. Now, with Down syndrome, you have even more craniofacial anomalies. I've only done a couple, but the results were not good. And so I think this is a really exploring the limits of what the balloon can do. That's still research at this point. Helger, do you have any experience?
Well, I pretty have the same experience as you have, Dennis. So with the cleft palate patients, we really struggle with them, and it's very important to look into the aspects that Dennis just mentioned. Is that if there is an inflammatory disease and the levator function is sufficient, then I would go for a balloon. The outcome is not outstanding, and it's far worse as compared to our standard patients. So I think the success rate is way below 50% in those patients. And in patients with Down syndrome, I think we don't have any good data on them either. So I think as long, looking at patients after radiotherapy, I have really not seen a really favorable outcome in this patient cohort. So I think the underlying pathology is different, and so we can't actually use a balloon in the majority of those cases with the high expectancy of success. So I would counsel the patient based on the experience, which is pretty identical from what Dennis mentioned, and then I thought we can try it if you and we could give it a chance if we see that there is sufficient movement of the muscles attached to the eustachian tube. I think we could go for it, but I would be very cautious in a consultation with the patient, not to make any unexpected expectations, just to be very open with the current results that we both have.
Okay. I'm glad you brought up the point of radiation. That comes up quite often as a question.
Yes.
And it's important to understand the mechanism, as you said, is very different. It's scar tissue from the radiation. It actually causes significant atrophy of the tissues within the valve of the eustachian tube. So about 80-85% of the patients who get radiation therapy to that region, to the nasopharynx, are going to get obstructive dysfunction with a serous effusion typically. But if you lyse all of that scar, they can easily become converted to patulous, and that has actually been reported in Taiwan. So I have successfully treated just a handful of patients with radiation very carefully, either a 30-second or a 1-minute dilation, just a minimal dilation. You don't want to overdo it. You can easily convert them to patulous. So you must be very careful. In fact, Mark Dean has inserted the balloon, the full length of the cartilaginous eustachian tube, but didn't even blow it up. And he treated one patient successfully. So caution with the radiation patients. Don't make them patulous. Better to undertreat and have to retreat than to make them patulous, because it would be very difficult to repair that.
That was going to be my question before the last one, and I don't want to. I appreciate your time, and I don't want to take any more time. I'm going to ask one more question, if that's okay with you, and it is with regard to the surface of the balloon. Professor Sudhoff, you have mentioned during the presentation, or you have compared the semi-compliance with the no-compliance balloon. What is your opinion about that? And if you could please give us some your experience.
Well, because as otologists, we are not so familiar with balloons, so we need to distinguish between compliant and non-compliant balloons. Non-compliant balloon will increase its width when you increase pressure inside. So I think with the non-compliant balloons at the moment, I think at least in our experience that works quite well. I don't have any experience with compliant balloons at the moment, but I think we need to look into different balloon designs, into different balloons, because I think if you look at cardiovascular disease, what kind of different techniques are available? And I think this is just the start and the beginning of balloon dilation, and there are different designs, different approaches, probably imaginable. And I think we need to have more research into that subject. But at the moment, I think with the balloons that are on the market by different companies, I think we have some really good experience, but it's just a starting point at the moment.
Okay. Anything to add, Professor Poe?
Well, so I have no experience either with compliant types of balloons that would expand further the more you increase the pressure. With the histological studies have been with the non-compliant balloons, and it was actually very interesting to see how the effect was very much at the surface, scraping off the surface epithelium down to the basal layer and crushing the submucosal inflammatory tissue, but deeper glandular tissue and the deep submucosal tissue was completely spared. So if you had a continually expansile compliant balloon, would that be a different story? We don't know. That it really needs to be studied. And I look forward to perhaps Helger's sheep model is very promising for that kind of an animal model. Before we close, Helger, it's so good to see you, and I greatly appreciate all of your wisdom. Thank you for sharing it here.
But then it's good seeing you, and it's always a privilege and a lot of fun working with you. And it's really inspiring to get your ideas, and it's really helpful. And it's always been a really great support. And I would like to thank you for our friendship and from all the knowledge that I could gather from you.
Well, I've been learning from you, the master, sir. Thank you.
Thank you.
And thank you to Spiegel and Thijs. We really appreciate this opportunity to be with you and to join all of you in the who've been sticking with us for so long this afternoon. Thank you.
Thank you, all of you.
Well, thank you
for your answers as well. I wanted to say that there are a lot of questions still. We don't have enough time, but thank you for taking time and answering these questions. It was very valuable time. And if there are any other questions, we will be happy to receive these questions via email, and then we will address them to the professors. Thank you very much for your time.
Right.
Thank you.
Yeah, so we are right on top, 2 hours. I'm pretty amazed, and also amazed about the quantity and quality of questions that we have received. So it is a clear indicator that shows the high awareness and interest in conducting BET. So this is a great result, a nice outcome. So thank you again for all your time and all your answers. But before we come to an end here, I just want to make a quick announcement. We will host on a quarterly basis webinars next year, and the next one will be end of Q1 next year in March, talking about pediatrics. So if you want to stay tuned, just follow us on LinkedIn, and then we are very happy to see you next year again. But from my side, I'm very happy about this webinar and wish you all a great weekend. All right. Thank you.
Thank you.
Thank you all.